Welcome to Board Pearls. This is episode 4 of the GI Emergencies chapter in the Special Populations and Acute or Supportive Care module. In this episode, we cover the last two mechanical and structural GI emergencies, esophageal perforation and Boerhaave syndrome, where imaging guides the operative versus stenting decision, and acute colonic pseudo-obstruction with the Ogilvie cecal diameter threshold and neostigmine. The last episode handled the ingested object and the caustic burn. These two run on the same Q plus threshold plus intervention shape, and in each, the threshold is a mechanism in disguise. The clock starts when the esophagus tears or when the colon stops moving. Move to esophageal perforation. Esophageal perforation can be spontaneous from forceful vomiting, the Boerhaave syndrome, iatrogenic from endoscopic dilation or biopsy or EMR or ESD, traumatic, or from caustic injury or foreign body. Iatrogenic perforation accounts for the majority of cases overall. Boerhaave is the high-yield emergency on the boards. The mortality is approximately 10 to 20% for early intervention within 24 hours and exceeds 40% for delayed diagnosis, and that 24-hour threshold is rooted in tissue plane mechanics. The macular triad of Boerhaave is forceful vomiting, severe chest pain, and subcutaneous emphysema. The full triad is present in approximately one-third of cases. Subcutaneous emphysema in particular may be absent or appear only after several hours as air dissects along fascial planes from the mediastinum into the neck and chest wall. The recognition stem is a recent forceful vomiting episode from binge drinking, eating disorder, hyperemesis gravidarum, or post-anesthesia emesis. The pain that follows is retrosternal or epigastric and radiates to the back, with dyspnea, fever, and signs of mediastinitis or sepsis as time elapses. The classic perforation site is the left posterolateral distal esophagus 3 to 5 centimeters above the gastroesophageal junction, where the longitudinal muscle is thinnest and the wall lacks the buttressing of adjacent structures. That anatomy is why the pleural effusion that develops is typically left-sided. CT chest with oral water-soluble contrast, or with intravenous contrast and oral effervescent agents, is the preferred initial imaging study. It reveals pneumomediastininum as the cardinal finding, pleural effusion, subcutaneous emphysema, and potentially the perforation site itself. Water-soluble contrast esophagram with gastrographin is the alternative when CT is unavailable. Barium contrast is avoided initially because barium granulomatous mediastinitis is a feared late complication if perforation is confirmed and barium leaks into the mediastinum. A normal chest radiograph does not exclude the diagnosis in a high-suspicion patient. Initial management is nothing by mouth, intravenous fluids, broad-spectrum antibiotics, antifungal coverage in severe disease, and nasogastric decompression placed under fluoroscopic guidance to avoid passing the tube through the leak. The antibiotic spectrum is dictated by contaminating flora. Oral anaerobes and streptococci track from the upper esophagus into the mediastinum. Gram-negatives reflux from the stomach into the mediastinal space. Coverage of both compartments is required with piperacillin tazobactam or meropenem-based regimens. Empirical antifungal coverage is added in severe disease because the mediastinum is a low-clearance space where candida overgrows once antibiotics suppress the bacterial flora, and reactive coverage after culture is too late. The treatment decision turns on the 24-hour threshold, and the threshold is mechanistic. Within 24 hours, mediastinal tissues are still amenable to clean primary closure. The contamination has not yet established the dense fibrinous adhesions and friable inflammation that destroy operative planes, and the leak is the dominant problem. Primary surgical repair with mediastinal drainage and gastric or jejunal feeding access is the historical standard for Boerhaave and large iatrogenic perforations, and it is associated with the lowest mortality. Beyond 24 hours, mediastinal contamination, fibrinous adhesions, and tissue friability make primary repair fail. Sutures pull through inflamed tissue, and the repair leaks again. Reopening contaminated tissue planes worsens the contamination. Management, therefore, shifts to covered self-expanding metal stents that seal the leak from inside the lumen, combined with mediastinal or pleural drainage by interventional radiology or thoracic surgery. The contaminated tissue planes are left to declare themselves and be drained percutaneously rather than reopened operatively. Small iatrogenic perforations identified at the time of the index endoscopy can be closed primarily with through-the-scope clips or over-the-scope clips. The defect is fresh, the surrounding tissue is uncontaminated, and the perforation has not had time to track. Conservative management with antibiotics, drainage, and nothing by mouth is reserved for very small contained perforations in stable patients where the leak has self-sealed on imaging. Move to acute colonic pseudo-obstruction, the Ogilvie syndrome. The boards test this as a 4-step algorithm anchored by a Cecal diameter threshold and a Neostigmine with cardiac monitoring decision. Rule out mechanical obstruction. Support Neostigmine. Colonoscopic decompression. The chronic pseudo-obstruction differential and the small bowel motility framework live in the motility chapter. This is the hospital onset decompressive algorithm half. The pathophysiology is autonomic imbalance with relative sympathetic overdrive and parasympathetic underdrive at the colon. The imbalance is often unmasked by electrolyte derangements, opioids, antipsychotics, anticholinergics, retroperitoneal inflammation, postoperative state, severe medical illness, or spinal cord injury. The right colon dilates more than the left because it is physically larger and because it is particularly dependent on parasympathetic vagal input that the imbalance disrupts. The typical vignette is the hospitalized patient on opioids who develops abdominal distension over 48 to 72 hours. About 86 to 90% of patients have multiple comorbid illnesses: postoperative orthopedic, cardiac, or intra-abdominal surgery, sepsis, ICU admission, severe burn, retroperitoneal hemorrhage. The instinct under stem pressure is to read distension plus opioids as ileus and watch. That instinct is right for the first 48 hours and wrong after. The first task is to rule out mechanical obstruction. A treatable mechanical cause masquerading as Ogilvie will not respond to neostigmine and may perforate during conservative management. CT abdomen and pelvis with intravenous and oral or rectal contrast shows a dilated colon without a transition point, with the cecum and right colon disproportionately dilated. The differential at imaging includes mechanical obstruction with a transition point, and sigmoid or cecal volvulus with a coffee bean or whirl sign. Toxic megacolon in severe colitis also belongs on this list, recognized by mucosal abnormalities and the clinical picture of severe colitis. A water-soluble contrast enema is used when CT is equivocal or when retroperitoneal pathology obscures colonic anatomy. Initial supportive management addresses the precipitants and is the answer for the first 48 to 72 hours when the patient is stable and the cecal diameter is below the escalation threshold. Nothing by mouth. Nasogastric tube to suction for proximal decompression. Rectal tube for distal decompression. Ambulation when feasible. Electrolyte correction, especially potassium, magnesium, calcium, and phosphate. Discontinuation of opioids and anticholinergics where possible. Treatment of underlying illness. Body position changes between prone and knee-chest leverage gravity through the dilated colon. This bundle resolves roughly 80% of cases. Methyl naltrexone 12 mg subcutaneously can be considered in opioid-induced cases because peripheral mu-opioid receptor blockade reverses the opioid effect on motility without crossing the blood-brain barrier. The evidence in acute colonic pseudo-obstruction specifically is limited, and methyl naltrexone is not first-line. Escalation is triggered by cecal diameter over 12 centimeters, persistent distension beyond 48 to 72 hours despite supportive management, or signs of impending perforation. The cecum is the perforation-prone segment because Laplace's law dictates that wall tension rises with diameter for a given transmural pressure. The largest diameter segment fails first. The risk of spontaneous perforation is approximately 3 to 25%, with up to 50% mortality once perforation occurs. Cecal diameter over 10 to 12 centimeters and duration of distension exceeding 6 days are the inflection points. About 10% of patients have some degree of right-sided colonic ischemia identified at colonoscopy, which itself raises perforation risk during decompression. Neostigmine 2 mg intravenously over 3 to 5 minutes is the pharmacologic agent of choice when the conservative bundle fails or escalation is needed urgently. Neostigmine is a short-acting anticholinesterase parasympathomimetic that reverses the autonomic imbalance by raising acetylcholine availability at colonic ganglia. It restores parasympathetic drive to the dilated colon and produces rapid evacuation of gas and stool. Cardiac monitoring, during and after the dose, is mandatory. The parasympathomimetic effect produces bradycardia, occasionally severe, plus hypotension, bronchospasm, and salivation. Atropine 1 mg should be drawn up at the bedside for rescue. Glycopyrrolate, a peripheral anticholinergic that does not cross the blood-brain barrier, can be co-administered to mitigate bradycardia and other peripheral muscarinic effects without reversing the central promotility effect on the colon. Contraindications to neostigmine are a list the boards test directly: mechanical bowel or urinary obstruction, recent myocardial infarction, severe bradyarrhythmia or conduction disease, active reactive airway disease because of bronchospasm risk, seizure history, peritoneal signs, suspected ischemia, perforation, known hypersensitivity. Colonoscopic decompression is the next step when neostigmine fails, is contraindicated, or cannot be repeated. The technique differs from routine colonoscopy because the colon is not prepped, and the goal is decompression rather than diagnosis. Minimal carbon dioxide insufflation is preferred because it absorbs faster and worsens distension less than air. Narcotic sedation is avoided because it would worsen the dysmotility. Ischemic mucosa is identified carefully. A decompression tube is placed into the right colon over a guide wire so that ongoing gas evacuation continues after the procedure ends. Efficacy of colonoscopic decompression has not been established in randomized trials. Observational data suggest immediate decompression in 70 to 80%, with a recurrence rate of 30 to 40% that often responds to repeat decompression. Surgery, cecostomy, colectomy, or ileostomy is reserved for clinical deterioration, peritoneal signs, cecal diameter persistently above 12 centimeters after exhausted medical and endoscopic options, perforation, or refractoriness to all other therapies. It carries high mortality because patients who reach the surgical threshold are usually critically ill from the underlying illness that drove the pseudo-obstruction in the first place. So pull these two threads together. For esophageal perforation, the 24-hour window separates clean primary closure from sealed stent and drainage. The mediastinum is the patient's friend in the first day and its enemy after, because the tissue planes change. So within a day you repair and beyond a day you stent and drain, while a fresh iatrogenic perforation caught at the index endoscopy is clipped on the spot. For acute colonic pseudo-obstruction, the cecal diameter threshold of 12 centimeters and the duration threshold of 48 to 72 hours move the patient from the conservative bundle to neostigmine, then to colonoscopic decompression, then to surgery. Laplace's law explains why the cecum fails first, and the contraindication list for neostigmine explains why every dose comes with atropine at the bedside. That closes the GI Emergencies chapter. The next chapter is GI Nutrition. We will work through refeeding syndrome and the NICE criteria, then hospital malnutrition with the GLIM criteria, and why albumin is not a nutrition marker. We will cover enteral and parenteral access, short bowel syndrome and teduglutide, and the fat-soluble and water-soluble vitamin and trace element deficiencies, and the malabsorption and post-bariatric patient. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of Episode 4 of Chapter 31, and I'll see you in the next one.